Good morning and welcome to our 2022 Center for HIV Prevention and Health Services Integrated Statewide meeting. My name is Aaron Davis and I am the Deputy Chief of Program Development in the Center, and we are excited to have you join us today and Thursday for what promises to be a great event. This year, our theme is Improving Health Outcomes by Focusing on Health Equity. Over the next 2 days, you will observe various presentations, panel discussions, and participate in breakouts that will hopefully make the connection between the importance of ensuring health equity for our funded HIV prevention and care programs and better health outcomes for vulnerable populations. We are joined by presenters from across the state and beyond who will offer their own perspectives of how we get to a more intentional place of health equity. So a few housekeeping items. First, we want you here for these next 2 days. We want you present during that time. And we realize that work is in a virtual environment means that you have other activities that may draw your attention away, but we really want you here and present so that you don't miss anything. Second, we invite you to explore the website for all the great features that are on there, including our meeting agenda, resources, group and private chat features, and a listing of our speakers. Third, because we always get asked, PowerPoint presentations will be made available after the conclusion of the event. So you don't want to miss that. And fourth, if you experience any technical difficulties on the platform, please select the message support feature option at the bottom of your screen where you can email our tech team and they can assist you further. So we are ready to get started. For our first morning session, we will have an introduction from Dr. Peter DeMartino, who is the Chief of the Infectious Disease Prevention and Health Services Bureau. This will be followed by a presentation from our Bureau's Health Equity Mission by Carmi Washington-Flood, who is the Chief of the Center for Faith-Based and Community Partnerships. Following Carmi will be a presentation on differentiated care from Jean Taylor, Clinical Process Improvement Coordinator for Quality Management in the Center for HIV Prevention and Health Services. Finally, we will have Bobby Rogers, who is the Deputy Chief of Program Improvement in the Center, who will introduce our speaker for our keynote presentation. Thank you so much, and take it away, Peter.
Good morning, everyone, and welcome. I'm very proud to be welcoming you to this meeting. I'm also incredibly proud of the theme of today's meeting. Health equity merges completely with our mission and vision. Although you'll be hearing more from Carmi Washington-Flood today about the Bureau's work to achieve health equity across all of our programs. But our mission in the Prevention and Health Promotion Administration, to which the Bureau belongs, I always focus on the 3 words of leadership, partnership, and vulnerable populations. That is really what we are doing. While we at MDH provide leadership, we are only as good as our partners, and we are always focused on vulnerable populations. Since we always talk about the Prevention and Health Promotion Administration, FIPA, I thought I'd give you a quick overview of where we sit in state government. So we're right down there in the bottom left-hand corner under the Deputy Secretary of Public Health Services, Dr. Jinlene Chan, who sends her greetings today. FIPA serves Marylanders across the lifespan, from before they're born in maternal and child health, all the way through environmental health, cancer and chronic disease, infectious disease epidemiology and outbreak response, and then our bureau, the Infectious Disease Prevention and Health Services Bureau. Our bureau is Maryland's response to sexually transmitted infections, including HIV and viral hepatitis. We are also the very proud home of one of only 3 state or jurisdictional level public health units dedicated to drug user health, our Center for Harm Reduction Services. In collaboration with local health departments who are our primary constituents, IDPHSB works to meet the evolving sexual and drug user health needs of all Marylanders with a particular focus on health equity and undoing racism in the healthcare system. That has always been one of our focuses, And I'm incredibly excited that over the past 2 years, we have been making that the forefront of our work. Here's our organizational structure broken down not by centers, by what we do. So we have 3 major goals: community engagement, capacity building, and workforce development, which is our Office of Faith-Based and Community Partnerships, and our Center for STI Integration and Capacity. We do surveillance and disease transmission interruption, which is our Center for HIV Surveillance, Epidemiology and Evaluation, and our Center for STI Prevention. We also support prevention and care direct services across the state through our Center for Harm Reduction Services, our Center for HIV Prevention and Health Services, the Maryland AIDS Drug Assistance Program, and our Center for Viral Hepatitis. We have 2 major themes running through everything we do. We have our funding, where we have a fiduciary responsibility to taxpayers who, whether it's federal or state funding, we manage it. And we also have our public health mandate, focusing on how we improve the sexual health and drug user health of all Marylanders, regardless of what we actually pay for. So our major goals are community engagement, disease and drug market surveillance, data use for public health action, including disease transmission interruption, centralized distribution of resources such as naloxone and point-of-care tests, directly funded prevention and care programs, capacity building and technical assistance, clinical quality improvement initiatives, dissemination of best practices, and workforce development. We provide subject matter expertise in planning, implementation, and evaluating high-impact healthcare and supportive services with the aim of addressing the social determinants of health, particularly for several key groups, including Marylanders who use drugs, LGBTIQA+, and same-gender loving individuals, and Marylanders experiencing homelessness. We are also called upon to serve during outbreaks. So human monkeypox virus, Mpox or MPX, became an issue this summer. And because it is a sexually associated disease, we have been seeing the vast majority of transmissions in Maryland being sexually associated. Although it has not been declared an STI yet, our Bureau has been at the forefront of ensuring that we are part of the comprehensive outbreak response in Maryland. You can actually use your phone and take a picture of that QR code, and it will take you right to our website, health.maryland.gov/monkeypox, where you can find our new pre-registration system for vaccine. So for individuals seeking MPX vaccine, you can register through our website. Back to HIV. I know many people in the room are Ryan White provider or CDC funded entities. And I just wanted to go back to, we are more than what we fund. It's important to understand that across the state, only about 1 in 3 people living with HIV are actually impacted by the federal Ryan White HIV/AIDS program. So it's incredibly important as we move into our 5-year integrated plan for 2022 through 2026, which is due to the CDC and HRSA at the end of the year. We keep in mind that we are meeting our fiduciary responsibilities, but also our public health mandate. To that end, we've held over 132 hours of community engagement sessions, both our cells meetings, as well as our suites, our stakeholder wisdom, experience, engagement, and tactical sessions. We have 2 left before we submit the draft integrated plan. Now, if you're wondering, how did 132 hours of community engagement happen and I didn't know about it? Here are some key contacts where you can be more engaged with Maryland Department of Health's activities for sexually transmitted infections, HIV, viral hepatitis, and drug user health. As we move into finalizing our Maryland integrated plan, here is our framework. We are working from a basis of equity towards holistic wellness. and we are borrowing pillars from the Ending the HIV Epidemic initiative to diagnose, treat, prevent, and respond to HIV, no matter where it happens in the state. Our goal is to truly embrace ending the HIV epidemic and getting to as few transmissions as possible. If we meet that goal, Maryland will be a place where less than 83 new infections are identified in 10 years. In order to achieve that, we need to create a more responsive, sustainable, and destigmatized service delivery model focused on health equity. Thank you so much for all you do, and enjoy today's meeting.
Good morning, everyone. I am Carmi Washington Flood, and I happen to sit under the Office of Director within the Infectious Disease Prevention and Health Services Bureau. There, they allow me to serve as the Chief of the Office of Faith-Based and Community Partnerships. And within that sphere of operation, we have been on a journey within the Bureau over the last 2 years and what we call our Health Equity Brain Trust Work Group. This group consists of multiple staff across the agency who have come together to build within first so that we can serve better without. We have taken time deliberately to take a look at who we are, the operations that we perform, the communities that we serve, the needs that we want to fulfill, and the obligations that we are there to meet. We have taken these in a deliberate and very intentional way to move beyond just the mission and vision statement that is put out by both our administration and our Bureau as a whole. We decided as a group that we wanted to present, and this will be the very first time that this has ever been presented publicly at any time, is the commitment statement from the Infectious Disease Prevention and Health Services Bureau to the state. This is something that we take to heart very seriously, and we are moving forward with health equity in everything that we do. So for the very first time, I am going to present to you our commitment statement and walk you through parts of how we got to the whole. To start off, our commitment, meaning we have pledged to do this. We are hand in hand walking together across the centers and the offices. Our commitment as a Bureau is to partner with communities to achieve health equity for all Marylanders. That means every center, every office, every operation that we perform has health equity as a foundation on which we are going to stand. We do understand that pictures are worth 1,000 words. So this presentation is integrated with several images that you have become familiar with seeing. We understand that folks at first thought equality was the way to go until we looked that equality, giving everyone the same, did not mean that everyone got what they needed. When we say that we are to partner with communities to achieve health equity, it says that we are looking at where the community stands, where they presently land, and then we are looking at what is needed or how to get them to the places where they can receive everything that is needed for them, no matter how much needs to be added to their place, position, and or framework. We are committed to making that happen. This image has been shown and shared across many spectrums, and we want people to keep this in mind as they are thinking about equity. How will you help people reach the great things that are available to them. How will we help and work together to get people where they need to stand, so not only that they can survive, but that we are operating where people can thrive? We are committed in our commitment statement to say that our priority is to advance social and racial justice, and we are committed to undoing racism within our public health systems. Why is this necessary? Because racism is at the root of disparities. Institutionalized prejudice and discrimination impact people's health across the board. We can't move beyond without recognizing that negative impact and then working deliberately to change that format, to change that structure, to change the mindsets that are operating in those environments, and to deliberately move forward. Will it take reframing and reorganizing and reconstructing? Yes, it will. But we are committed to doing that. An image that helps seat that. Here you see this triangulated structure here, where you see health equity in the middle, because health equity, again, is the central focus of where we are moving as we go forward. It involves our services, it involves data and research, and it involves all of our programs. Within our services, we have to build capacity, both internally and externally, across those that we fund, and then to leverage our partnerships and relationships with those who receive funding from other arenas. We want to use our data and research as platforms where we can move forward, not to simply continue to report the same information, but to use that information whereby we can not only justify and rationalize, but where we can celebrate giving greater support in areas where we can demonstrate greater need. That will call for some institutional change in some places. That will call for some institutional change in some operations. That will open some additional doors for people to walk through that before have not had the capacity to walk through. We're going to see some changes in some programs over time, because we will deliberately and intentionally, again, make sure that those areas are met with what they need. And will it require some policy change? We're looking forward to that. We're looking forward to changing some of the structures and the excitement that brings as we celebrate health equity in the middle of everything. It is our commitment to be responsible and to responsibly serve Marylanders without any bias or discrimination, and ensure open access to services and resources. You say, what does that look like? Again, here's an image that captures it very well. Equality would simply be giving everyone a mode of transportation. But when it comes to equity, it is the mode of transportation to take us on this incredible public health adventure where everybody can get there in a format and in a style and an operating mode that meets their needs directly. Here is our statement all together. We as a Bureau, we are committed to partner with communities to achieve health equity for all Marylanders. Our priority is to advance social and racial justice, and we are committed to undoing racism within our public health systems. It is our responsibility to serve Marylanders without any bias or discrimination, and to ensure open access to services and resources. How are we going to do that, you ask? Well, we're going to reach. because our commitment actually defines our reach. We're going to be respectful, meaning we will approach everything with the necessary cultural humility. We will be equitable. We will make sure that communities get what they need to succeed. We're going to be accountable. We will report back in real time and make real changes where necessary. We are going to be community driven, meaning we will stay in touch and in contact on an ongoing basis to hear from the community as we move forward. And we are going to be health focused because we do think that we can achieve a Marylander where families and individuals thrive. Thank you so much for allowing us to share our commitment with you this morning.
Sorry about that. Good morning, everyone. My name is Jean Taylor. I am the Clinical Process Improvement Coordinator for the Quality Management Division for HIV Prevention and Health Promotion Services at the Maryland Department of Health. Thank you all for joining us today. Today, I will be presenting on the information that was gathered from the Differentiated Care and Health Equity Survey. So, since fall is like right around the corner, I thought it would be kind of fun just to start off with a little joke for the day. So why did the scarecrow get promoted? Because he was outstanding in his field. Okay, so maybe that was a little corny humor. Okay, moving on. So differentiated care and health equity. So the survey, it was sent out to like 23 different jurisdictions in Maryland, and it was done through a Cognito survey platform, and that was in July. The goal of the survey was to gather information on several different items focused around differentiated care and health equity. So again, I want to thank everyone that did respond to the survey. It was a lengthy survey. It took time, thought, and energy. And kind of after the initial poor response rate, the survey was sent out again. All the questions that were asked, they were necessary in order for us to help identify gaps and offer support and suggestions to hopefully make your work a little easier and allow for better client outcomes. Unfortunately, due to the lack of responses, there was little data to work with. So therefore, my presentation, it just simply describes the results that were received. We will be sending out the survey again for those who did not fill out the survey the first time, or for those that may have not completed the survey the first time, but it will be sent out with just the differentiated care component for now, with the hope that it won't be so overwhelming. And then later on, we can send out the other component on health equity. And I'm looking to do that probably next Monday. I think it's the 26th, and it will remain open until the 30th. So we started off with the survey by asking about standard operating procedures. So often it's the case where a jurisdiction, they may only have one case manager, or they could even be just a part-time case manager. But during the initial intake, these are some of the main items that case management works on for a client. They're looking at their needs at the time of intake. Eligibility is determined. Referrals are made based on the client's needs. And I think most importantly is that a relationship is established with the client and a case manager. So in the survey, we did ask about vulnerable populations and any unique needs that they may have, and if those needs were being met. Providers use a variety of services and interventions to help meet the needs of clients in vulnerable populations. Here's some examples of ways that case managers assist the clients with needs. It could be translation or services for those hard of hearing. They may have in-house counselors for crisis situations, systems to rejoin the those that are previously incarcerated and help get them back into society. Recovery programs, community support programs, linkage to available resources. And again, most importantly is equitable treatment for all. So case managers, they may use some or all of these items to help strive to ensure the best health outcomes for their clients. They can do phone call reminders. They may be copying, faxing, scanning important documents for the clients. They provide the appropriate grade level education on medications and adherence to medical appointments. Again, referrals and screening for social disadvantages. And then they may do pamphlets and written materials that may need to be translated as necessary. And then we did ask about barriers and challenges with navigating through the HIV healthcare system. Listed here are some of the difficulties that are sometimes encountered when trying to obtain HIV services. I think the first two, the transportation and the housing, were huge. And then the rest were are listed here. Language barriers, missed appointments, noncompliance, unmet dental needs, and inconvenient hours. So then the second part of the survey kind of went into the health equity part. So listed here are some of the ways that case managers reported on how they addressed their clients when thinking about health equity. Always with fairness, justness, respect, being non-judgmental, and customizing clients' personalized needs. And the survey also went into cultural diversity and social determinants. The survey, most of the responses came back that case managers were being offered training through these resources like staff in services, the MDH trainings, the hub trainings. But however, there were some requests for additional training on cultural diversity and social determinants of health. So if anyone has questions, thoughts, comments, again, I want to thank everyone for listening and being here. And please, feel free to reach out to me if you have any questions. And that is the end.
Good morning. It is with great pleasure that I introduce this awesome professional and friend. The misunderstood social worker comes with over 14 years of experience in working with adjudicated youth, foster teens, as well as providing individual and group therapy to adolescents suffering from oppositional defiant disorder, ADHD, emotional disturbances, and bipolar 1 and 2. By incorporating traditional, artistic, and out-of-the-box clinical approaches to treatment, Joseph has been highly sought after by an array of programs, school programs, medical health clinics, and consultant groups for services and clinical consultations. A poet, engaging, stylish, community connected, and creatively driven, Joseph's stance on treatment is to heal yourself one issue at a time. The real work begins with acknowledging your fear and later confronting it. Furthermore, there is no set way of healing oneself, so all clinical and artistic methods can be applied. The misunderstood social worker is a master level MSW social worker who's licensed certified and board certified. I proudly introduce to you Joseph Williams, the misunderstood social worker.
Hi, good morning, everyone. I love that title. When I hear someone else says it, it makes me uncomfortable, but for me, it just makes sense. So today, I'm happy to be here this morning, and I wanted to talk about improving client HIV outcomes through health equity. So with today's discussion, I wanted to kind of dive deep into the work that we do and how we service the clientele that we work with and our consumers, and how oftentimes the way in which we present the work can oftentimes affect our outcomes. I always like to tell people you want to be able to hand services to a person on a tray, a beautiful tray, and you explain every piece of the meal, which will give them a better understanding as to what we are doing with them and the work that has to be done in order to have a better outcome. So without further ado, I wanted to just give a few definitions, right? So when we talk about health equity, that means achieving the highest level of health for all people. Health equity entails focused societal efforts to address avoidable inequities by equalizing the conditions for health for all groups, especially for those who have experienced socioeconomic disadvantages or historical injustices. And if you guys want to have a further understanding of that, when we talk about health inequity, when we talk about health disparities, oftentimes we can identify several vulnerable populations. Case management. So most of the work that drive, most of what we do is driven by case management. So when we talk about case management, overall case management can be defined as a professional and collaborative process that assesses, plans, implements, coordinates, monitors, and evaluates the options and services required to meet an individual's needs, right? I'm gonna read that again so everyone can understand. So we're talking about the whole person, the whole client, the whole consumer, a professional and collaborative process that assesses, plans, implements, coordinates, monitors, and evaluates options and services required to meet an individual's needs. Health inequity, what is that? So when we hear health inequity, we want to define it as disparities in health or health care that are systemic and avoidable, therefore considered unfair and unjust, right? So when we talk about, and we've had this discussion during the pandemic where we talked about, the lack of healthcare access or the type of healthcare that's accessible to vulnerable populations may not be the best of services, right? And so based on insurances, and we can go into a much deeper discussion about that, but we can do that later, okay? And then let's go there, case management. This is where it all begins. So most of the work that we are doing, it deals directly with the client and the management of their circumstance and situation. So roles of a case manager, what do? Evaluate the needs of a client. You get that through asking questions, through assessing, through allowing the client to tell their story. You identify those services needed. Once you've gathered all of the proper information, you create a client-specific service plan. You evaluate effectiveness of services while services are taking place, whether or not they're receptive to those things that they are accessing through you, through referrals. You act as a liaison between the services and the client. This is very important, guys, because we have to think in terms of the referrals that we make for some of our consumers and clients, however you identify them. Sometimes we make those referrals and we never follow up. We never make sure that the linkage is proper or whether or not the client understands the services that's being offered after it's outside of your scope of what you do. And you also assist clients with identifying their options in any given situation. That is the role of a case manager. Skills needed to be an effective case manager. So these are just some general skills, right? Needed skills for effective case management. So let's talk about ethics and values, how you see things. Are you able to understand and recognize what your limitations might be, what some of your quote unquote hangups may be when it comes to working with certain populations? Are you going to be the most appropriate with a client? Are you going to be understanding? What is your value system as a case manager, as a social worker, as a therapist? The knowledge. What do you know about the work that you're doing? The type of work that we're doing, what is the information that you've been able to store in your mind as to how to effectively service a client? Cultural competence, very important. So a lot of times we have to consider beyond just race and ethnic identity. We have to be able to understand a value system and understand that people come with their own set of ideas about life, about circumstances, about how to handle things. Those are the cultural norms. Are you culturally competent to be able to recognize and understand and meet a person where they are, even if you don't necessarily understand or relate? Can you do that? Advocacy. Can you stand up for the rights of a client? Can you advocate effectively in order to have their needs met most appropriately? Your service planning abilities is most important. How do you effectively present services? I always tell people we have to get out of presenting services to our clients on the top of a trash can. We just giving them information, telling them, hey, go call this program, do this, as opposed to how do we necessarily present that information? How do we create that linkage for the consumer, for our clients? And how do we make sure we're bridging the gap? Okay, so service planning abilities. Can you plan services properly? Leadership skills. Can you lead this case? Can you be an effective spokesperson for this client and their needs in circumstances outside of the client? And interpersonal competencies. I'm going to leave a question on the table for those people who are watching, because I really want to talk afterwards and I can be very wordy. So I want someone to tell me, what do they believe interpersonal competencies mean? Okay, so I'll leave that one. I won't go into detail about that one, but if somebody can put it in the chat, that would be great, because I love to talk. I love to interact with people. So we're going to skip ahead. Where do we go wrong? Where we go wrong as case managers and service deliverers. Where do we go wrong? This is an exploration of ineffective and poor case management, poor collaboration with clients and service providers. The number one, that comes from the lack of communication or the lack of understanding as to a client's needs. And a lot of times this can happen when we're dealing with clients as if we're on an assembly wheel, an assembly line, where we think everybody's needs are the same based on the similar situation, right? Insufficient training. Unfortunately, in the field of social services, sometimes we need bodies and we need people that have the licenses and the capabilities to be able to perform the work, but sometimes they're wilted into situations without being properly trained on the client population, the services offered, those items for which they need to know as a hands down, lack of understanding of clients' needs. Sometimes we can kind of have a multitude of different types of clients and we can have a huge caseload. And oftentimes we don't truly understand the client's needs because we have so many that we're dealing with. And that comes from not communicating. That comes from not doing the proper research, both on paper and with the client. Right? Barriers with communication and understanding. We're not only talking about language barriers. It could be the way that we communicate, the way a person reacts to their circumstances, the way a person may feel like they need to tell their whole story before they can tell you the story. And a lot of times when we're working in our field, we can be like, okay, we got to move quick. We got to move quick. And a lot of times we lose the most important things. If I was to give a brief example, sometimes we can just assume that our clients know how to take care of business. And that means making phone calls, having the soft skills. And then we present them with this information and they're like, I don't know how to do that. And then you're like, you're 34 years old. How do you not know how to do that? Then at that point, that's when the case manager becomes judgmental and not understanding, right? Assumptions about clients, who they are, what they may represent. Based on their histories, based on the way they came to us, we can assume things about them, i.e., oh, you're older, you should be able to do this on your own, right? Implicit bias. Okay, I'm going to leave another item in the chat. What does implicit bias mean in case management? If somebody can answer that question, that would be amazing. What is implicit bias? I would love for someone to answer that question as well. Burnout. As a licensed therapist, I've been working for about 20 years. And for the first time, I experienced burnout about 5 months ago. Burnout is just, I need a break. And a lot of times, some of us, we can't afford, or we don't have the time to take that break. So that's when you see the work not being as great. That's when we tend to do subpar work. That's when we tend to not put forth the best effort as to servicing our populations. Sometimes we can be in our roles and not understand exactly what we're supposed to do. And that's this is one of the major areas where we go wrong. The lack of understanding of the population, what we're supposed to do, how we're supposed to do it. And unfortunately, if I was to kind of veer just a little bit, a lot of us who work in case management, or when we're dealing with clients, sometimes we're pushing an agenda for a program manager or a supervisor. And a lot of times we're looking to appease that dynamic for the spaces of employment and doing well at work, and not necessarily thinking about the client. I hope that makes sense to everyone. Poor boundaries. Oftentimes over relating to a client, feeling like you can relate better, or just kind of flagging those necessary boundaries that you need to do effective work with the client, can also make us go terribly wrong when it comes to the service delivery. Lack of supervisory support. Sometimes it's very difficult to have a set time to meet with your supervisor based on clients' needs, based on dynamics that's happening in the office, meetings. It can be very difficult to just sit down and have like a clinical case management supervisory situation with your supervisor. And when you're left to your own vices, sometimes we can make mistakes. And what I've noticed, just with some of the places that I've consulted with, we tend not to catch problems that were brewing until after they've happened. So we have to do a better job sometimes in this field, where we're not always operating out of emergency when we see something brewing or getting ready to happen with a client situation. I'm going to go to the next slide. Examples. And I think I gave some. Stigma, discrimination, and bias by healthcare providers were among major barriers to care identified by the series of authors and disproportionately affected marginalized racial groups, people who use drugs, and sexually gender minorities. Those are some of the people who often have some of those biases, those discriminatory types of actions held against them, whether they're blatant, implicit. That's what we see. And that's what's been researched. Okay, what needs to change? What needs to change? I would love for people to put some stuff in the chat. What do you feel needs to change in case management when it comes to effectively servicing our clients, when it comes to effectively trying to gain better HIV outcomes with our consumers? Let's talk about it. Okay, these are some of the improvements to be made. So if anybody wants to say anything, just throw it in the chat. I love to read things, guys. So ways to achieve health equity in case management. Case managers can promote policies that support equality, fight for patients' rights, and facilitate communication to be a strong advocate. All healthcare professionals must demonstrate a culturally competent and inclusive practice to effectively address disparities. I'm gonna let that sit for a minute. Case managers can promote policies that support equality, fight for patients' rights, and facilitate communication to be a strong advocate. All healthcare professionals must demonstrate a culturally competent and inclusive practice to effectively address disparities. How do you get that? Through research, through looking at trends, to understanding what is going wrong, what's not working across all boards, and then being able to really fight and push for the right thing. I was always informed as a case manager, you are an advocate, you are a leader. Ways to achieve health equity in case management. Continue. All case managers must demonstrate a culturally competent and inclusive practice to effectively address disparities. This can be done through the creation of a safe environment, or a safer environment, free of judgment and oppression. We play a critical role in reducing inequalities and overcoming barriers to care for all people, regardless of race, ethnicity, age, socioeconomic status, ability, gender, identity, or sexual orientation. case managers have to strive to support all efforts to advocate for cancer patients. That was supposed to change. I'm sorry, guys. For all our patients with health issues, okay? And that's culturally and linguistically appropriate, okay? A well-rounded approach to case management and HIV care will ultimately benefit the patients in a variety of ways. An experienced case manager includes strategies to address barriers and disparities in all aspects of their work, even down to the way that they're handled at the front desk by the person. We have to remember these are the environments that we work in where they should feel safe and warm and inviting for all. Incorporating these skills will promote better coordination of care and access to resources, okay? Now, I would love to have a discussion. Does anybody have any questions? We can go on and on and on. And Bobby Rogers knows me very well, and I love to talk. So I was told that this has to be shortened. So this goes a lot further than normal. So if there are any questions, I would love to take them in the chat. I'll look through some of them. Okay. Hi, Bobby. Okay. Wow. If anybody have any questions or anything, Bobby, do you have any questions?
I do not. We're just waiting for those questions to roll in from our panelists or from our guests. So what questions do you have for Joseph at this point?
Okay, someone answered the question. They said interpersonal competencies means, to me, one's ability to maintain interpersonal relationships utilizing interpersonal skills, essentially relationship building to include trust, respect, and create a safe atmosphere. That was a wonderful answer. That was a wonderful answer. Yes, that was a beautiful answer. Thank you so much. The internal lens of bias that one has. That was the answer to implicit bias. The internal lens of bias that one has, right? And so that's a really great definition for implicit bias. And that's true, actually. It's like what's inside of you and what you believe it to be. I'm a much older man, so a lot of times when I'm walking past a group of kids getting out of school, I usually cross the street because I think they're horse playing. So that's just a thought that I have, you know what I mean? So right. Even something as innocent as that can be some of my own bias. I feel like they don't watch where they're going. I'm going to get knocked over, you know, and that's just what it is, you know, and that's a very kind of lightweight example of that.
Absolutely.
Yeah. I see another statement here. It says, since the pandemic, many organizations are struggling to hire staff. What is your understanding on this issue? I do agree. We've had a major shift in a lot of our programs right here in Washington, D.C., where we're finding it difficult to hire staff. And then a lot of times in those circumstances, particularly in fields of case management related to housing, related to mental health as well, they're hiring people, they're throwing them right into the belly of the beast. And a lot of times you have newer case managers who don't even know of resources, community-based resources in the city, which will ultimately impact the way in which we engage in care or how we're caring for the client. Not saying that you know, they can't receive support, but a lot of times they're wilted into situations. How did I identify and handle burnout? Oh, that's a wonderful question. Thank you so much for that. What I did, I spoke with my mentor. And I had a conversation and I started to compare the ways in which I was working and my reaction to the work compared to what it is today. And I was able to understand that I was taking on too much, trying to be everything in order to properly service the client, in order to maintain my own stability. And I was told that I need to take a break. So what I did, I just managed it and I started to set more boundaries with the way in which I work. And then I had to get those outlets, the gym, going for walks, literally turning off the phone and realizing once the work is done, I need to be done, and really connecting with people who aren't connected to my field, which actually helped me get out of burnout. And I do believe that if you notice that you're starting to get frustrated with simplistic situations with clients, if you find yourself not putting forth best effort of the work that you're supposed to do, it's always important to engage with your supervisor, with other staff members who are trusting and loving, who are caring. And when I say that, I'm saying in the most professional sense, that understands and they're not using what you're telling them against you, but in order to assist you.
Yeah. And Joseph, I would like to circle back around to the hiring of staff when it's so difficult to hire at this point. I think also to piggyback to what Joseph suggested, you know, we sometimes have to look into those who are younger, those who are kind of fresh out of college, and build a strong, what we like to call a wise counsel that can kind of go to the older case managers to ask questions about, you know, different strategies, different approaches to case management, to build them up. All of us sometimes have experience when we get out of college. They tell us we can't have this job because we don't have the experience. Well, how can you get experience if you're not given that chance?
Have to give them an opportunity. Yeah.
Give them an opportunity. So maybe in this space, we're able to build them, if you have the capacity to do so, to build them to be the best case managers that they can be.
Absolutely. Now, I do agree with that. And I do think that, you know, a lot of times, sometimes when you talk about the younger populations, some of our organizations don't have the manpower or timing to actually appropriately train and guide those younger people. And so a lot of times they tend to shy away from those opportunities to bring in that new energy because they know that they have to start from ground zero with training them, getting them to understand. But I believe that we all need a chance. And I'm starting to see a shift, even here when we're seeing younger people managing cases and having strong boundaries and having the energy to, you know, advocate for their clients. So I think that we need to continue to push for that. Someone said in the chat, setting boundaries is good as oftentimes I find myself working harder for the patient than the patient. So there's a fine line between enabling a client and advocating and assisting them. And we have to always, you know, revisit that with that client. Hey, it seems as if you're not putting forth that effort. What is it that you need in order to remain inspired? So, because at one point, I'm not going to be able to do this type of, you know, work with you. So how are you able to kind of put some things in place? Or what do you need further assistance with in order for you to be able to take care of some of these items on your own? You have to always put that in place. And there's nothing wrong with revisiting. And even if it causes some level of conflict, because and I don't want to, you know, make any crazy assumptions, but some of our work is tied to help. Most of our work is tied to helping others, but then some of our work, we tie it to help, but it's usually we're enabling them. And so we have to be able to clarify that. I hope that made sense to the people. Yeah. Any other questions, statements?
And Joseph, also to add on to that, you know, sometimes you got to set those boundaries and let them know, hey, this is a short-term case management situation. So we have to get what you need to get done. And it kind of gives them the boost to say, okay, I need to get it together. I don't have time to kind of piddle around. And we need to get what we need to get done because I don't have much time with this case manager.
Absolutely. Absolutely. And I just wanted to go back to this one statement that I made. I won't quote who said it because I think the name might be triggering to a lot of people, but there was a show that I watched when I was a kid a long time ago. And there was an episode where the daughter came home and she brought this amazing man, but she said, we're getting married next week. And the family never met the guy. And so they were talking at the table and the mother, the father, the siblings, they had an attitude towards this new guy. And he was like, you know, I went to MIT, I own a farm and yada, yada, yada. And the dad was like, you know what? We don't like you. And it's not because you did anything wrong. It's just the way that my daughter brought you here to us. You could actually be a great person, but the way you brought it to us, it makes us not like you. And he asked the guy, what do you like to eat? And the guy was like, I love steak. And he said, so if we were to make you a steak and, you know, prepare it the way you like it and put it on the top of a trash can, would you eat it? And he was like, no. And he said, right. So that's how my daughter brought you here. Right. And so we have to think in terms of how we are presenting services and opportunities to our clients. Some of these opportunities related to housing, related to employment, related to, you know, drug treatment, related to healthcare treatment could be great programs, as opposed to just giving them the information and making that referral. Why don't you call them? with the client? Why don't you have those conversations with the connection that you have over to the other organization? Let's set a time when we can meet there together. So the handoff will be appropriate, because to just tell somebody, call this number, they're going to help you with this, it just looks like you're just presenting it on the top of a trash can without giving them an opportunity to see that this is a safe environment. What if your client only trusts you and you've made them enough comfortable where they don't want to talk to anybody else, right? So we have to be careful about how we're presenting the services to people. Yeah. I find, go ahead.
And I see that there's a couple of good comments in the box. It says, can you talk about your effective strategies for retaining clients in care and how that might have changed in the last 2 years?
Wow. So that's a great question. And so most of my work is tied to individual therapy. And I've noticed that as the political climate changed, as the socialized climate changed, employment stuff changed, the needs of the clients changed, right? And so I always had to be, and I continue to have to be workable and adjustable. I may start off with a client coming in the door with depression based on, certain circumstances that have happened in their lives related to work, personal stuff, housing, and then those needs may shift to, okay, now I'm working too hard. I'm overwhelmed. I have no outlets. No one calls my phone. I'm unhappy. Similar situation, but a different dynamic. So you always have to be workable and be able to work past the shifts. In the past 2 years, I've had a lot of, for the first time in my career, I've never had people come to me for assistance, just to process everything that they're witnessing and watching, be it in politics, be it in the world. And, just to be quite frank, to have African-American men and women come to me, it was like, I have to stop watching the news. I'm worried about this. I'm worried about that. This country's doing this, and I'm scared we're going to go into war. And I'm like, wow, usually we're talking about, relationship stuff, but I literally had to assist them with processing what's happening around them. And they were like, I have nobody else to talk to about it. You know what I mean? And so those needs had shifted in the last 2 years based on what was happening, based on the climate, and things have been very tense. So the most important thing that I had to do to retain clients was to create that safe space of relaxation, of calm, of understanding. I did a lot of social media diet and news diet stuff with clients, as well as really presenting a lot of creative social calming skills, pro-social skills related to going for walks. Let's go to a park. Let's do this. So I had to shift a lot of my practice based on what was happening globally. I hope that answered the question.
It definitely did. It definitely did. And I think it's a great segue to the next question. What are ways you think leadership can create an environment that makes case managers feel supported and be able to speak up for their clients?
You want the real truth or the fake truth to that answer, to that question?
Give us the palatable, the truth, and then give us the real tea.
Okay. So I believe that, it's all about the agenda of the office, and it's all about the agenda of those in charge. The way a ship runs is how its captain is running the ship and those connected to the captain. I believe that when people are not effectively managing things outside of themselves, they often bring them to work. So you see powerlessness personified through control and lack of support at work based on lack of control in personal life, right? And I'm not sure if people caught that, but I want people to pay attention to that. So the leadership is most important, particularly when it comes to creating a supportive environment as opposed to a punitive environment. Right? Punitive environments work when they're necessarily applied. But I used to work with an agency here that dealt with foster youth, one of the government agencies, and everything was emergency mode. Even when you've done everything correct, how dare you go to a table with lawyers and outside practitioners, and you come to the table as a group and you have your supervisor questioning whether or not you handled something when in fact you're the case lead and everything's done, but they're approaching you as if you're an enemy of the case. And see, we've had to have those conversations about what does support look like, or what does being punitive or power tripping look like? So you get better work when the staff that you manage feels the most supported. And they feel like it's an opportunity for them to be able to communicate clients' needs, and they're being supported both individually from the supervisor and collectively with the other people that do the work. We have to learn how to bridge gaps and communicate with one another.
Absolutely.
I feel like that was a pep rally speech or something.
It was, and I love it. I'm loving it. And I think the last question that we have here, it says, I find it challenging, or more so of a comment, I find it challenging when a client doesn't prioritize their health the way I wish they would. They have the right to make their own decision, but since I work in a public health setting, I carry the responsibility of worrying about public health as well. What is your response to that? How can they better manage that, that worry?
Oh, that was great. And beyond your thoughts about what the client needs, I think it's always great to go and revisit the client's own personal outcomes, and then to always put the most effective and the most positive outcome that could potentially happen based on services that you're offering. So it's always great to revisit with the client, hey, you know about this, or what about this? And I understand that you want to do this, but have you looked at these things? Let me show you what this looks like, in order to be able to, get them to make another choice, or to get them to buy into it. What I tend to do in situations like this related to health, I always ask them about their future goals outside of their health situation. And then I bring it back to, how do we feel that we can accomplish that, based on the way we're going today, and how we can go about it moving forward. So always dig into the things that they want for themselves. And if they don't have those things, help them identify what some of those goals are, and then work from a more positive and healthier plan for themselves. And thank you for asking those questions. Thank you so much.
Awesome. And I think there are no other questions at this time.
Thank you so much, guys. I really appreciate being invited here. I feel so honored. And this was great for me. Thank you so much.